afternoon, everyone, and welcome to the first session of our new series, Listening to Long COVID, brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Please note that we are recording this session so we can share later. Your names do not appear in the recordings of the session, nor does anything listed in the chat. My name is Raquel Romero. I am so glad to see you. I hope your family is doing well. I'm a physician by training, and I'm going to be the facilitator for the ECHO session today. We have a lot of information and very important information to share today, but before we get started, I have some notes from our ECHO IT. These sessions have the closed caption option. You could access that in the bottom of your Zoom window and select Show Caption option. Please stay muted unless you are speaking. You can use the chat function to share your comments, your perspectives, and your questions during the session today. You can also use the chat if you have any questions about your connection, and you can send a private message to the ECHO IT. For our attendance records, I would like to ask if you please add your name, affiliation, and title and email in the chat box. Again, this is for our attendance record. We are so excited to announce that this series provides free continuing education credits for physicians, physician's assistants, nurses, pharmacists, technicians, and social workers. Towards the end of the session, you will receive information in the chat for a link for the evaluation. Once you complete the survey, your certificate is automatically generated, and a link will be sent to you. You can reload this certificate at any time, but please note that this is going to be open this Tuesday, 5 p.m. For those that are new to the ECHO, ECHO stands for Community Healthcare Outcomes. This is a model of lifelong learning and telementorship that connects healthcare workers and providers to create a community of practice and learning. And this is a very special space that you can share, and we can share resources and strategies to support our community. This series, Listening to Long COVID, explores the effects of the long COVID and the shared management strategies, including complementary approaches to deliver care. At each session, we want to have didactic and educational presentation, a panel of experts. After that, we want to watch a video of someone whose life has been impacted by long COVID. Then we want to have a discussion opportunity for us to ask questions and comment and suggestions. With that, I will do the introduction for our Confianza team, and I would like to start with Dr. Barton, the didactic presenter. You are muted, Dr. Barton. Thank you so much.
All right. Well, hi. Are you ready for me to share?
If I have a second, yeah, thank you so much. And I would like to also thank you so much for your presentation. Let me just introduce the whole team. I have Andrea Rochat, and we'll see the screen. Andrea.
Hi, everyone. Andrea Roche, Program Manager of the UT Health San Antonio Echo Super Hub. Really glad to be here.
Thank you, Andrea. Dr. Rosenfield, moderator for the session today.
Hi, good afternoon. Jason Rosenfeld. I'm Assistant Professor at UT Health San Antonio and Implementing Director for Health Confianza.
Thank you. Dr. Bergen.
Hi, I'm Ruth Berggren. I'm an infectious disease specialist and internist, and I'm a professor at UT Health and a member of the Health Confianza team.
Thank you very much. Ms. Paula Winkler.
Hi, I'm Paula Winkler. I'm with the South Central Area Health Education Center, a proud member of the Hub team here. So glad to see everybody.
Thank you very much. Mia.
Hi, everyone. I'm Mia Vento. I am the Program Manager for Health Confianza, so you'll get all my annoying reminder emails as the course goes on.
Thank you for sending all the reminders. Joaquin Abrego, I think I saw you.
Peace, y'all. It's Joaquin Muerte. I am the community health worker with Health Confianza.
Thank you very much. And as a part of our agenda, we have next didactic from Dr. Barton, and then we'll have a video testimonial. Finally, I would like to say that ECHO is all teach on our environment, and invite you to and encourage you to participate in our session today in our conversation by sharing your experience, your questions, and perspectives. With no more from my end, Dr. Barton. Now, yes, this is your space, please.
Okay, great. Thank you. So thank you for inviting me once again. So my name is Theresa Barton. I'm pediatric infectious disease here at UT Health San Antonio. I'm going to share my screen quickly and hopefully everybody can see that well. Okay.
Dr. Barton, it looks like we tried it out, but now it's showing presenter mode. Do you know how to get out of that? You do?
Yeah, I'm just going to do this and then reshare it with the different screen.
Okay. Of course, it's the opposite of what we see in our tech check. Perfect. Go ahead.
Okay, so today I've talked about long COVID in the past and at some of these sessions, but I thought today to take a little bit of a different flavor because I feel like, you know, what I hear a lot with my with patients, and of course reading on, you know, social media and other things is a lot of frustration on the side of patients who are people who are suffering from long COVID, feeling like they're not really getting heard, and that the doctors don't seem to always know what's going on. So so I'm hoping to focus a little bit more on, you know, what we think might be going on, and are there some hints of things that can, interventions that can help. So I have nobody's paying me to give these talks, so I have no conflicts of interest. Although if somebody wants to like give me some kickbacks, I guess I could take that. And so first of all, I want to just give a very brief overview of the, you know, the physiology of the virus SARS-CoV-2, which is a virus that causes COVID. I'm not going to go super into this, but this is a virus that that we inhale, and it attaches to cells largely via what's called the ACE2 receptor. And then once it is in a tissue or in a cell that contains that receptor, it then begins to it opens up its RNA and it begins to, using the cell machinery, to make the proteins to make new viruses. So it's not a retrovirus that integrates into your cell necessarily. It's one that makes versions of itself using that protein building mechanisms. And then from there, will then trigger your immune response involving all sorts of different cells, and I'll mention that in a moment. So this ACE2 receptor is present on numerous tissues in our body. It's present in our lungs, in our respiratory epithelium. It's present in cardiac tissues, in the pancreas, I mean, in the placenta, like all sorts of tissues contain this receptor. So in theory, if this virus had access to one of those types of cells, it could potentially infect one of those cells. When we respond to this virus, we have basically two kinds of responses. One is our cellular response, where cells that are infected are targeted by your cytotoxic T cells. And then your B cells will make antibodies that will stick to all of the viruses that are circulating around and try so that they can no longer bind to more cells and that the immune system can clear them more quickly. And that's sort of the normal response to most viruses, including this virus. So we know that in addition to that, a common phenomenon with SARS-CoV-2 or with COVID is a very robust immunologic response where you get what's called a cytokine storm. And that's where these immune system cells become very stimulated and they begin releasing their inflammatory proteins excessively. And so it's been proposed that perhaps, you know, persistent activation or inappropriate responses are the things that lead to severe COVID and many of the complications that we see. And the most common complications, or at least the most notable complications that we encounter with somebody who has acute COVID infections, are the thromboembolic complications, whether that's, you know, deep venous thromboses or, you know, intracranial clots or strokes, myocarditis or heart inflammation, and unmasking autoimmune diseases. And those have been described from the very beginning of the COVID pandemic as frequent complications in people who were being hospitalized with COVID-19 infections. So of course, like those, that represents a severe, you know, a group of people who have more severe disease. And we haven't had, you know, we've slowly gained information about what happens with people who have more mild disease. I've shown this study before. This is one of my favorite studies. It's not an amazing study, but it's very unique in that these were young, healthy college athletes in the early part of the COVID pandemic who were as part of the Big Ten, you know, sports franchise, and they were required to undergo if they had tested positive for COVID, they were required to undergo a battery of cardiac tests in order to return to play. And so and most of them had mild or even no symptoms at all, and were tested kind of routinely, you know, like they were being tested in order to play, in order to go to games. And if somebody tested positive, whether they had symptoms or not, you know, they were obviously weren't going to be able to play, and they had to go through this battery of tests in order to be able to be cleared to return to play after their infection. And they had almost 3,000 athletes that had tested positive. So it's a sizable study. And what they found is that about 2% of these healthy college athletes who had tested positive for COVID had some kind of evidence of having had myocardial involvement, even if they had mild or asymptomatic infection. And so I think this gives us a hint at you know, how deeply involved this virus can be in our tissues and the places where it can cause inflammation, even if we don't know that it's there. Of course, the other part that's particularly relevant to long COVID are the neurologic effects of COVID, and that can range from, you know, direct viral invasion of neural tissues that might lead to something like the loss of taste and smell, or the blood clots, such as strokes, or other types of encephalopathies or neuropathies, and all of that can be confounded by if somebody has severe COVID and ends up in the ICU with the ICU psychosis and the use of steroids and other, you know, medications. And so it becomes very complex, but the things that COVID does inside our bodies is complex, and our immune system response is likewise complex. So how can these subsequently lead to long COVID? Well, there are 4 basic theories. One is that perhaps there's a viral reservoir. Perhaps there are areas in the body where the virus doesn't go away, it isn't cleared, and it's still there. The other is autoimmunity, right? So does your immune system react, overreact? Is it doing something wrong? Did it get triggered to misbehave? And now this dysregulated immune system is creating autoantibodies against your own tissues. You can also have the idea, which I think is actually kind of compelling, for latent virus activation. You know, we know that herpes viruses, such as herpes simplex virus and Epstein-Barr virus, will be latent inside our body, and periodically, if we're stressed out, they might pop up, which is why people get, you know, fever blisters when they're stressed or they're ill. And so the idea is perhaps this virus is then triggering, you know, reactivation of otherwise latent viruses, and what we're seeing with prolonged symptoms are the effects of these other viruses. And then there's the concept of long-term inflammation, which we see in things like HIV infection, where you have many of the complications of HIV infection are not only from the immune deficiency, but like cardiac disease related to persistent inflammatory, low-level inflammatory responses. And so is there persistent inflammation that's leading to these prolonged symptoms? And there's evidence for all of these things that has been published. So for instance, this is a study that shows, you know, changes in cytokine profiles in people with prolonged symptoms for many months following their even mild to moderate COVID infections, compared to those who don't have prolonged symptoms and compared to those who were never infected. There hasn't been a lot of data suggesting that there's really persistence of virus, but there have been a few, and in this particular series, they did find that that certain viral proteins, particularly the spike proteins, could be detected in about 60% of the long COVID patients, compared to none of the COVID infected but not long COVID subjects that were included. And so for several months. And that was molecularly not growing the virus, but, and so some hints that perhaps, there may be places where the virus is sticking around or continuing to produce, spike protein, and that may be triggering some ongoing immunologic response. So getting to sort of long COVID, which is the basis of our talk, this is really, it goes by long COVID, but there are many other names for this. So some people call it long hauler. The official name with the NIH and the CDC is post-acute sequelae of SARS-CoV-2 infection, or PASC or PASC. And so you'll see in most of my slides, I will refer to it as PASC. Some of my slides, you will see a little p, big P, and that's pediatric PASC, because I'm a pediatrician and you shouldn't forget the children. But this is very similar in its nature and its symptoms to other post-viral fatigue syndromes, chronic fatigue syndrome, myalgic encephalitis. These are all terms that kind of refer to the same general thing. So the definition is a symptom onset or persistent symptoms 4 weeks or more following an acute COVID-19 infection, characterized by fatigue plus various other symptoms. So fatigue should be a part of it. And the dominant feature is typically a post-exertional fatigue, which means that you do something, and it doesn't have to be a big thing, right? It doesn't mean that you have to go to the gym. I mean, you might just go to the grocery store, or maybe you just got up that day and put on, took off your pajamas and put on your clothes, and then you feel overwhelmingly tired and then feel like you need to sleep for the next day. It should be intrusive into your daily activities and not explained by other conditions. And that last piece is kind of the key to making that diagnosis. So the neurologic features of long COVID vary from, exercise intolerance, weakness, the brain fog, pain, persistent pain and paresthesias and headaches, as well as dysautonomia, such as like orthostatic changes, getting dizzy when you stand up, temperature regulation, where your temperature's up and down, or hot flashes or cold flashes. And so those are kind of the common neurologic features, and each patient is a little bit different. They'll have some of this or some of that. Not everybody has the same symptoms. Are there any predictive factors? Well, possibly. So severe disease, ICU stays, pulmonary embolisms, and myocardial involvement during your acute infection are all things that have been associated with the development of long COVID. I will add to that MISC, which is this multi-inflammatory syndrome seen in children, as well as potentially unvaccinated status. So how frequently does this occur? So the data on how many people get prolonged symptoms after their COVID infection is hugely variable. And so just as an example, I have a list here of here's a bunch of studies in children, and they all have different results, ranging from 8% to 58% of children developing long COVID symptoms following their acute COVID infection. So you can see that the definition is important, but because it's so variable, it is a little bit difficult to kind of pin down how frequently this is occurring. So just last month, the Kaiser Foundation put together a review of kind of long COVID, and they estimate that they have, based on some census reporting, that about 28% of our population currently has ever had of people who had COVID have had long COVID. And so I think that this looks like it's anywhere between 5 and maybe 20, 30% of people who get infected will develop some kind of prolonged symptoms. And for some people, that will be persistent for a very long time. So what do we do when we see these patients? Well, in my opinion, the first thing that we really need to do is to make sure that they didn't have an organ involvement that maybe wasn't previously identified that might be leading to their problem. So to make sure that they didn't develop myocarditis and a subsequent cardiomyopathy, that they didn't have some kind of cerebrovascular accident, looking for autoimmune diseases, and looking for things that might mimic those same types of symptoms, such as undiagnosed hypothyroidism or diabetes or mental health problems. So are there tests that we can do that can help us to diagnose long COVID? Well, not really. So there have been a lot of studies looking at various profiles of chemistries, inflammatory markers, and essentially there's really not any major differences in the inflammatory labs or the pulmonary function or cardiac function once you kind of take everybody combined. Similarly, there's not a lot of difference in the lymphocyte profiles between the patients. This particular study, they actually were trying to say, oh yeah, there's a difference. But actually, when you look, the symptomatic, like long COVID and not long COVID, but previously infected cohort, basically they were the same without any significant differences. So the lab tests are not particularly helpful. And this was a large review looking at a huge number of inflammatory tests and autoimmune tests in people with long COVID with various types of symptoms. And they did find differences in many tests that were significantly upregulated, and some of them were were lower in the long COVID cohort. But as you can see, it's very heterogeneous. And so you can imagine one single patient might fall anywhere in this Venn diagram. And so it's not really diagnostic if some of these are abnormal, because they may or may not be abnormal. And so I would say, if you're looking for like, oh, I'm going to send this cytokine profile, you might want to save your copay because it may not actually be quite as diagnostic as your clinical exam and your history. And really listening to the patient and the kind of symptoms that they have is really what you need to make that, as opposed to doing a bunch of tests. There are some guidances. So this is a guidance for the PM&R colleagues regarding with a consensus guidance on the treatment, assessment and treatment of people with PASC. And basically the mainstay of this is that to set achievable goals, to focus on their specific symptoms. So if their problem is that they have persistent migraines, addressing the persistent migraines as part of their treatment, or if they have dysautonomia, addressing that. And then overall, working on improving their physical, mental, and social well-being. I can't express more importantly the importance of that sleep-wake cycle and being sure that people are getting adequate sleep and trying to establish good quality sleep and good healthy sleep hygiene as a way of restoring, against fatigue. And part of it is really coping and restoring, because these are people who've gone from being mostly like really normal, healthy, robust people to feeling really bad all the time. And not that the cause is a mental health problem, but certainly the repercussion is a mental health problem, that it's very difficult to cope when you've made that kind of transition in your life. And so providing psychological support to help them cope and providing physical therapy to help recondition them. On the pediatric side, there's a similar guidance. It's not a consensus guidance, but this is an article that I find actually very well structured for how to manage these patients. And I'm not going to go into all of these things, but it actually lays out for each discipline, if you're the primary care doctor, doing some basic screenings such as your, CBC and your ferritin and your Epstein-Barr virus panel and things like that, referring them if they need to be referred, and then, for psychologists, there are some profiles that you can do and behavior modification, techniques to try to overcome some of the intrusiveness of those symptoms. For cardiologists, like what would be useful if somebody's having largely, chest pain or shortness of breath or exercise intolerance, what are some testing that you could do with that person to try to diagnose an underlying problem, and what are some potential treatments for that. And so even if you find it kind of overwhelming, you can at least go and say, okay, this is what my patient has. Maybe these are the tests that will be helpful. And these are the kind of treatments that if I'm not familiar with them, I could look into that to see, is something like propranolol going to be useful for this particular patient. And so it goes on with ENT, pain. And so this is again that article. It's in Pediatric Annals from November. And I think that you guys will get the slides, and I made the link at the bottom is clickable to be able to access that article. So looking at, and preparing for this lecture, I was like, oh, I want to see, let me pull out what are the latest, good treatments or things that have been looked at. So I just put into a PubMed search and I put in, long COVID treatment. And I got 10,000 articles. So you can see that the volume of information getting thrown at us is really overwhelming, and it's really difficult. I do my inpatient rounds every day, my clinic twice a week. I don't have time to go through 10,000 articles if I have a patient who has long COVID. And so I think this is what many doctors are kind of being faced with, is there's this overwhelming flood of information of varying quality, most of which is not good quality. And then our patients are also getting flooded with the same information, because these same studies are getting translated into lay information and being shared on social media or Facebook groups or Reddit or, wherever it is that they're getting their information when they're joining together in their support groups. And it really can be hard to sort out what's useful and what's not useful. In addition, if that wasn't enough, early in the pandemic, a lot of preprint articles suddenly were becoming available to us because we needed to know about this information right away about how is this virus behaving. But that is still continuing. So in addition, we also, in my 10,000 articles that came to me were things that are still aren't even peer reviewed. It doesn't mean they're not a good study, but it means they still haven't even gone through that whole process of being kind of validated before they get released to the world and the public grabs onto them. So I picked out just a couple of things. So there's always a lot of questions about supplements, and you can find lots of studies on vitamin C, vitamin D. They're all out there. They're all of varying, most of them are small studies of varying quality. I think there is some, evidence that arginine and liposomal vitamin C may improve some subjective grip strength and physical measurements for some of these patients. The latest thing are antihistamines, and so again, there's several studies looking at different antihistamines. This was one that kind of popped up prominently when I was looking at some patient groups, and they used an H1 and an H2 blocker, and they had a little scoring system, and they did show that there was some improvement. So over here, that those with the those who took the antihistamines, if they were down here in the pink zone, it showed that they were getting better versus getting worse on the change in their symptom score, that they were significantly improved using the antihistamines. But somebody should do a journal club on this study, because they were self-selected patients who chose whether or not to go on antihistamines. And they also showed that 26% of the untreated inpatients actually had improvement at 8 weeks of follow-up as well. So, the studies are hard, and it's hard for patients to understand what's a good study and what's not a good study. So for the antihistamine question, for instance, yes, there are some patients that may experience improvement with, combination H1 and H2 blockers, but the data is poor. It is, however, similar to vitamins and supplements, a relatively low risk intervention. So, is this something somebody could try with their patients? Certainly, and if they're asking about it, getting familiar with, what is the state of the data, of course, is helpful. So will these patients recover? Well, they will recover over time. And so, but it is very slow. And in the Danish cohort in kids, about 20% of patients still had symptoms at 13 months, which is actually better than what we see typically in adults. There are trials that are ongoing for long COVID, and we can talk a little bit more about that. The latest trial that seems really everybody's kind of excited about, at least in the media, is this ibutamoren, which is not a new drug, but is a drug that has been gotten a lot of attention for trials in amyotrophic lateral sclerosis, or ALS, as well as multiple sclerosis. And then I think lastly, and maybe more importantly, our patients need time to recover. And so many patients will come to us requesting disability help with getting their disability applications. And yes, under the ADA, this disorder is considered a disability. And so there is a process for that. And the CDC website actually has a lot of good information on seeking disability, and how to deal, and like a guide for employers, how to deal with, with that. So I do recommend this, if you have patients who are seeking that. So in summary, the immune response to SARS-CoV-2 is complex, can lead to varying sequelae in a variety of different body systems. I think screening for kinds of tissue damage effects in patients who have long COVID to identify whether there is something physiologically treatable that would be high priority, and using kind of a holistic restorative measure, sleep-wake cycles, physical therapy for reconditioning and gaining strength, and psychologically supporting them through a really, really difficult illness. Good quality data on therapy is actually hard. The data is not hard to find, but good quality data is hard to find. And really, I think advocating for recovery time is a key way that we can help our patients. And I'm sorry that I ran over a bit, but thank you, and I'll take any questions.
Thank you very much, Dr. Barton. This is very, very informative presentation. I wonder, is there any question at this point to Dr. Barton? If no questions, you can always add those questions in the chat that we can try to follow up later, but I would like to now ask Dr. Rosenfield if you please help us with the presentations for the videos that's next on our agenda.
But before I do that, I see that Dr. Berggren has her hand raised.
Sorry, Dr. Berggren. Yeah.
Hey, I'll be quick. Thank you so much, Dr. Barton, for giving us that really great overview. We have a broad variety of people that are in our audience today, and I noticed that you kind of landed on the fact that H1 and H2 blockers might help some people. And would you mind just unpacking that for us, since not everybody knows H1 and H2 blockers?
Sure. So there are different types. So histamine is a chemical that some of our cells make, and there are different types of histamine receptors in different tissues. So very simply, there are some of these are related to like allergies, right? So like if you have allergy medications, you take an H1 blocker. And if you, for your stomach acid reduction, you would take an H2 blocker. So it kind of depends on what type of receptor it is that where the histamine is targeting. So these have been used for a variety of different anti-inflammatory effects in other inflammatory conditions. On the pediatric side, we actually use H2 blockers, or the kind that blocks stomach acid, for these recurrent fever syndromes. And so the idea is sort of binding up these inflammatory receptors, or receptors that are connected to kind of an inflammatory cascade, to block them and block that inflammatory cascade in a more gentle way than something like steroids that are immunosuppressive.
Thank you very much, Dr. Barton and Dr. Berggren, for your question.
And
I see Dr. Rosenfield. I see also in the chat there is a question from Evangelina Ramirez. Would you want to did you would like to read your question? I don't see. Let me read it. How successful is a provider likely to convince a patient that there is an end to long COVID symptoms to elucidate them from seeking disability status? Dr. Barton.
So I would say, one of the challenges is that every patient is a little bit different, and we don't always know individually how long is that patient going to take to improve. Many patients will be improved after, 8 weeks, which is 2 months, right? Many patients will still be really, really struggling at a year. And so I would say that I don't know that as a provider, I don't want to be in a battle against my patient who is seeking disability. If they feel so disabled that they can't do their lives, I don't know that I want to dissuade them from seeking disability. I want to understand, like, what are the things that are intrusive in their lives with their symptoms? Can we improve those things so that they can go on, they can continue to go to work or school or be functional? And in the meantime, because I don't know the timing of that. So disability actually may be very appropriate for some patients. And so I think understanding what it is that they're kind of going through is part of that. So I don't have a great answer for that. Like, are there going to be people who abuse the system? Of course, there's people. I mean, there's no matter what system there are going to be people who abuse the system. But I think that if, when I have a patient was playing basketball in high school, and now they can't even put up with a half day of school, or else they go to sleep for 3 days, like that patient is severely impaired. And I not only do I want to try to get to the bottom of helping them to feel better, but part of helping them to feel better is not pushing them too hard, and that means that they need the time to get better.
Thank you very much, Dr. Barton. Just a reminder that everyone's circumstances may be different. Thank you very much. Okay, now I will ask Dr. Rosa to continue.
I have a question. Hi, my name is Jasmine. So I work at a shelter, and some of our clients sometimes have chronic conditions like asthma and stuff like that. And some of them have got their COVID shot and some of them haven't. What can I do to prevent in my community to help them with long-term COVID?
I think that, part of the reason why these, prolonged, like these post-COVID syndromes are so, people struggle with them, is because they are intrusive into their lives. And so I think that as a community provider, I think helping them to access mental health services, helping them to access traditional health services are, because many people can't, right, are probably something that community members who are working with, chronically ill people can advocate for.
If I could just add to that great answer, this really is about access to healthcare, which is a problem that we were having before COVID. And we have people who are unhoused before COVID, during COVID, and after COVID. So getting people plugged into care where possible is important. We know also, and we'll hear no doubt in this series, that even people who are plugged in and have health insurance can't necessarily get into a physician or a provider that treats post-acute COVID syndromes or long COVID. And one of the things that we will be looking at in this series is some complementary and alternative approaches and other modalities that are supportive of individuals who are struggling with long COVID, even if they aren't something that results in a prescription. Thank you.
Excellent. Thank you so much.
Thank you. Thank you. Eddie Sanchez? I think I hear. Mm-hmm. Would you please unmute yourself?
Here. Okay. Can you hear me?
You.
Okay. Yes. Hi, I'm a chaplain, and I used to work with the government as a contractor, and I got tested positive, and I knew I was positive. This was back in August of 2020, and shortly after that, I started having a lot of the classic symptoms of long COVID, and nobody would listen to me. They kept saying it was this and that and the other. I was given a lot of meds and nothing worked. So as time has gone on, one of the things I did go to was a neurosurgeon. I mean, I went from being one of those guys that would go for my regular checkups, but that was it. And all of a sudden I've got 11 or 12 doctors that I'm seeing for every different thing. And people were not taking me seriously. And my joints would lock up. I would fall. I had brain fog. I had all the stuff there. And finally, it was a neurosurgeon that referred me to a physical therapist. That the physical therapist is actually one that kind of gave me hope. And I had a good friend of mine that used to work for Dallas, Baptist Baylor hospitals up in Dallas. And he used to say that when a person loses hope, you pretty well lost everything. And that's where I was going. So I was able to do some things. But the thing is, I've got several other friends that are in they're either counselors or also clergy that have gone through similar situations or have had to deal with folks that are dealing with this. And I'm now working with a large corporation part-time, but I was never able to get disability. I was never able, like I said, even because nobody would sign off on me, I was kind of left on my own. So I had to go ahead and take Social Security and so on, just to exist. And so, I'm thank you, Dr. Barton, for the things that you've reinforced. And I'm dealing now with some folks that are dealing with some of the issues that they've had in the past with COVID, and they're still dealing with them. And so the question I think is going to be is when will we get to a point where some of these folks, and like myself, can be taken seriously and say, I left. I mean, I was thinking I was going to go back to work within a few days, and I loved my job. I got to travel a lot, and there are just a lot of perks to it. But I think my doctors thought, hey, this is just another guy just trying to play the game. And the only time I was taken seriously was when I fell outside of one of the doctor's offices. That they came out, they saw me fall down, and they came out to help me up to make sure I was okay. But other than that, it seemed like, there's nothing really wrong with you, and I was asked point blank if I really liked my job, and I said I love it. But
thank you, Mr. Sanchez. Thank you so much for sharing. Sorry to hear that, but this is the essence of those sessions: learning from each other and bringing those stories to learn how we can manage and help ourselves and our community better. Thank you so much for sharing that. And actually, you told me to move to the next part, with basically it's going to be the video and testimonials from people that have been kindly sharing with us those experiences. And thank you so much. And like Dr. Berger, more to come, because we have a series prepared for you all. Dr. Rosenhill, thank you so much.
Yeah, and I just want to reiterate that, Eddie, thank you so much for sharing your story with us today. And this is the exact purpose of this learning community, is to help us as healthcare providers, as folks working with individuals in the community, whether we're community health workers, nurses, physicians, public health professionals, recognize and acknowledge people's lived experiences. And so just as a quick reminder to everybody, the Health Confianza Project was based upon this principle of rebuilding trust with our communities and our health and social service systems, and also building people's confidence in their ability to make the best health decisions for themselves. And the ECHO series has been a core part of this, really focused principally, and I'm going to quickly just share my screen as a reminder to folks that have been in our sessions before, about the 6 core communication skills that we've really been emphasizing through this ECHO series. So this is our 4th series that we've launched, 2 focused on clinicians, physicians, nurses, medical assistants, community health workers in a clinical environment, one, community health workers writ large across the community. And this is a fourth meant to be like an all-star cast, bringing us all back together and really to get to the point of what Eddie just shared. How do we acknowledge people's lived experience with long COVID, whether or not they have had a clinical diagnosis, right? And so really what we're focused on in these next 6 sessions is on these 2 core communication skills. How do we incorporate active listening into our daily practice? And how can we acknowledge people's perspectives? And that is really, I think, at the heart of what Eddie was sharing from his own experience, not having that acknowledgement. And what we've done is we've curated 6 stories from our community of individuals who have either are suffering from long COVID or are taking care of family members or loved ones that are struggling with long COVID. And just as a reminder to set the stage for this, we have objective ways and subjective ways of assessing people's illnesses, right? I think we're really good oftentimes at the objective side. Check a box, you answer questions, I can figure out what your diagnosis is. What we want to really focus on here is how do we hear people's stories? What are the questions that we can ask ourselves and ask the individual sitting in front of us to gather those stories and recognize people's lived experience? So as we watch this first video, and every time we meet, we're going to have one of these short videos, I want you to keep those questions in mind. And then we're going to have a discussion on the back end of this testimonial. So Raquel, I think I'm good, and I think we'll launch the video.
Thank you.
If I can describe my lungs, they feel like if they aged. And that's something I don't think it's going to go away. Because even though I've been trying to exercise or do whatever I can, I struggle with the breathing. It was already going to be a year, and we were already saying, hey, we got through this year without it. And then it happened. You know, the good thing about it is the family got the minor symptoms, nothing drastic. I was the only one that ended up at the hospital and got everything with it. I started having fever, body aches. The first evening, then it escalated to like pain on the kidneys. The doctor said I started developing neuropathy. I couldn't walk. I couldn't just maybe 10 feet away from going to the restroom. You know, someone had to help me. If had it not been for my wife that would stay up night and day, she went through the whole thing with me, and you know, she did more than most nurses do, because she was there 24 hours. My sugar levels started getting all whacked up, and they gave me a lot of steroids. And when I went home, instead of giving me insulin, I just went with the steroids, and everything started escalating. My sugar levels went up to 485, and that gave us quite a scare. Not to forget the little details, because those are the most important things that can go this way or that way. When they sent me home with the steroids, the part of having to have had insulin could have, I think maybe could have avoided the sugars to still keep in other words, developing a little bit, because it kind of like, it almost looks like if the steroids, because of the steroids, I was eating like every 2 hours, full meals. Because of my breathing, like I couldn't really do certain exercises or anything like that. I didn't have the lungs to do it. That was the biggest obstacle for me to get back in shape. And it's already been a while, and I don't think I'm there yet. And I'm still struggling with that. The sugars, I guess it triggered it to where I'm still dealing with that. And even the doctors always talking to me about putting me on medication for it, because my body, I guess, is not fighting the sugar the way it used to be. Trying to stay alive. Yeah, just like everybody else, trying to live a normal life too at the same time. Not look at it in a negative way, but trying to stay positive and encourage people still about the vaccine. And a lot of people I know a lot of people are still afraid of it, but I had already gotten the COVID a second time, and because of the vaccine, it avoided all of those problems. I mean, it was just something real minor. I had to stay away from work, but nothing like before. So right now, the main thing is to encourage people. You know, still, that's why I'm here. You know, it's telling my story from the beginning. You know, it's like they say, you pay it back by telling your story and trying to help people, that there is light at the end of the tunnel.
So we've got a few minutes left here, and I would just like to start a conversation, and maybe this is one that we can continue over the course of this learning community over the next few weeks together. But I'd like to just start with what did folks observe? What did you hear in Eddie's story, in both of our Eddie stories, honestly? What did you observe? Would anybody like to share just like their general observations and thoughts? Yeah, Ludi?
A lot of what I hear, and I heard it from these two individuals, is that they don't feel like they're being listened to, like they're being acknowledged. So that's the main thing that they feel, that not even at times, you know, their families, you know, so that's like one of the major things that I've observed from individuals that I've encountered with this long COVID.
Yeah, thank you, Ludi. And I think Sandra Sanchez in the chat mentioned something similar. He wanted to be heard. People weren't listening. I think it's a common thread that we've heard. Other yeah, Tess, sorry.
I was just going to say also that Eddie Sanchez said that people just didn't, like, not only not hear, but just like didn't believe them, like thought they were making things up. And you know, I've certainly seen, I've seen most of the patients that I've had who've had these kinds of syndromes have been people who were like super robust and doing their stuff, and which makes it very easy for me to believe them. But some of them have been people who are kind of chronic complainers about other stuff, right? And so I think that as healthcare workers, we sometimes discount those folks. And I was just talking to my resident, you know, today about this, and I was like, you know, even like the boy who cried wolf ultimately got eaten by the wolf because the wolf existed. So so I do think that, you know, we do have to leave ourselves open to believing our patients.
Yeah, and in the chat I see from Anne, desperation. Lourdes mentioned people feeling appearing sad and feeling like people don't believe them. And so the same kind of theme of acknowledging perspectives and a sense of sadness because of that lack of acknowledgement. And then Guadalupe put in the chat, paying attention to the details, that strong reminder that for anybody conducting assessments and supporting patients and families, that it's, you know, how do I frame this? It's more than just a job sometimes, right? It's really acknowledging people, seeing the human in front of you and not just the illness. I think that's one of my favorite parts of the quote that started that video off, is that, you know, we're more than just the illnesses that we present with. Ruth, did you want to jump in? I saw you kind of, yeah.
Well, I wanted to say thank you again to both of the Eddies for your generosity in being with us today and sharing your stories. I'd like to leave something empowering, which is that there's actually a billable ICD-10 code for those who are healthcare providers. It's UO 9.9. For those who aren't healthcare providers, if you're getting pushback or your family member is being told that this is all in their head and it's not a thing, there's actually a diagnosis code for post-acute COVID syndrome. So I hope that's empowering for some people. And then, you know, I heard that there is light at the end of the tunnel and that there are people who can help. So I want to keep us focused on the hopeful aspects of these stories too.
Yeah, I appreciate that, Ruth. And I want to build off of what Sandra put here in the chat about how do we elicit these stories from our patients or the individuals that we're speaking with. So one of my follow-up questions to kind of wrap us up here is, you know, how does this story, as well as Eddie Sanchez's story that he told before, how does it help or not help you think about how to engage with others like Eddie? Are there nuggets that you can take away from this for your own practice, whether it's in a clinical environment, in a community environment, or otherwise? What are the lessons that you can draw from these stories? Are there better ways of soliciting these stories than maybe what we normally do?
I guess on my end, I could just to remember to put be open, and just remember to not, it's so hard. I just was trying to think and I don't get the words together. Give me a second more.
No, you're good. It's not an easy question. I recognize that. I think we're having to put the mirror up to ourselves and our own ways in which we communicate and engage with people around us.
Yeah, especially like having empathy. Oh, so go ahead. I'm sorry.
Yeah, Junda, I think you were.
Yeah, but you could finish your thought. I can remember mine. Go ahead.
I was just going to say, just to have empathy and remember to put your own thoughts on side, or your own empathy. I'm not the empathy. I can't think of the word. Go ahead. Sorry.
Thank you, Jasmine, for sharing.
I was just going to say that as long as people are in a world of 10 to 15 minutes a patient, that's not going to get better, right? And it's making providers miserable. It's making patients miserable. I realize I say that from the luxury of having stepped out of that. I can spend as much time as I want to with my patients here, but it's a real systemic problem.
Yeah, thank you, Junda. Guadalupe, I see your hand.
Yes, I was thinking how, because of what Dr. Wu has mentioned, the limitations in time at the clinic, like clients, patients, and families, we should be reminding them to reach out to their patient advocates or community health workers within the clinics or systems, whether it's community-based or at the clinic, to be part of those conversations. Just like there is patient navigators for breast cancer, like, you know, reach out, ask, are your providers, do you have that support system, and make them part of your team when you go and consult with the doctors, because they can be listening to the stories that you share with your CHWs outside of the clinical setting, and that's where a lot of details also are revealed. And to have a strong thing, I think a patient navigator CHW will be ideal.
Yeah, I really appreciate that, Ruth. I'm just going to put a little bow on that and then hand it over to you, because I agree. And that's the beauty of what I think this learning community is bringing, is that we get to hear from each other, from your perspective, Guadalupe, as a community health worker and social worker, Dr. Bergeron's experience as a physician on the front lines treating patients. And that's where we can build these relationships and find ways to complement the work that we're doing in all the different environments. Ruth, with a quick comment, and then we'll wrap this up.
Just wanted to ask Dr. Barton if she could mention what are some ways to prevent long COVID from happening in the first place?
Well, I mean, of course, the best way to prevent long COVID from happening in the first place is to not get COVID. And so, working on the various, self-protective ways that we can. And of course, some of the ways to prevent not getting COVID are, vaccination that can help to prevent infection in the first place. And also, because prolonged COVID does have some association, not for everybody, but there is a risk if you have more severe disease. Presumably you have more inflammation and therefore more tissue damage and more risk of long COVID. So, certainly getting vaccinated reduces your risk of having severe COVID disease. Many people are using, Paxlovid or antiviral medications to kind of blunt the disease when somebody does get it, to reduce severity. And then I think, careful follow-up, like as a provider, following up with our patients to see how they're doing after they've had COVID, to kind of screen them more expectantly early on for symptoms rather than waiting for something to be going on for months before it comes to our attention.
Yeah, and I would just say that there is a culture of toughing it out and people not seeking care until they're really, really sick, and it might be too late to take the antiviral. But in this case, the wiser thing might be to reach out early to see if you're an individual who your prescribing provider thinks would benefit from an antiviral like Paxlovid. And if so, there are data that suggest that getting on Paxlovid can decrease your risk of having long COVID. Thanks.
Yeah, and I want to just thank everyone. We didn't have the time for the robust discussion, and we'll continue this conversation. I hope everyone will come back next week and for the following 5 weeks to continue this discussion. I wanted to point out a couple things in the chat before I hand it back over to Raquel. Joaquin emphasizes the importance of language, hearing people and the words that they use, and not necessarily replacing them with our own words. I think that is a real important part of this. And so recognizing sugars, what does that mean to people, and what are the implications of that? And so I just want to thank everyone. Eddie Sanchez for sharing the story in real time, Eddie for sharing his story virtually. This series will continue. The goal here is, rather than having the formal case discussion, these are our cases. These are the real lived experiences of individuals in our community who are still managing their long COVID symptoms. And there's a lot of learning that we can do here. Raquel, can I call on Guadalupe real fast, or?
Yeah,
okay.
Thank you. Just real quick. Are there in San Antonio, Bexar County, are there any, for people that don't have a primary care physician, are there any pharmacies or any providers that are writing the prescription if they get a positive COVID test to start the treatment, or they do, well, that's my question.
There are, I think at this point, 3 remaining test and treat pharmacies listed on the national finder.
Thanks, Dr. Wu. But do they need the prescription from a provider, or they can actually give you the treatment?
Yeah, no, test and treat means you get it all done there all at once. They will test you and then they will give you the treatment.
Okay, absolutely. Thank you.
Wonderful. So thank you again. As I mentioned, this is the launch. We're starting from the clinical perspective, and we're going to move our way out into the community and start looking at alternative ways of helping people heal through indigenous approaches, through faith, and through arts. And so I'm going to wrap it up. Thank you so much for everyone for sharing today. And I'm looking forward to spending the next few weeks with you all.
Thank you very much, Dr. Rosenfeld. Thank you, Dr. Bergen, and to you all to be part of this discussion. And this is just the beginning. Please come and turn your in due time. Next week is gonna be March the 3rd. But also, you say it was saying that do not wait. Symptoms are real. That was in the comments. Please stay with us next week. Until then, have a wonderful week. Take care.